So I'm delighted to introduce Komla Ahlijah, I believe, Manager of Data Science and Enterprise Analytics at Centene Corporation, leading a team of scientists and statisticians responsible for all data-driven research and development initiatives. Previously, Komla was the data scientist lead for Commerce Bank, using Amazon Cloud Computing to develop fraud mitigation strategies across consumer, commercial, and credit card portfolios. And I think it'll be interesting to hear the dynamic, the similarities and the dissimilarities between those two applications. Komla received his master's degree in applied mathematics from the University of Nebraska in Omaha, and a BS in mathematics with a concentration in actuarial science from there as well. Komla was born in Lomé, Togo in West Africa, and is fluent in English, French, and his native language of Mina. He founded and is co-chairman of the not-for-profit toysfortoga.org, providing materials for needy and at-risk children in Togo. Please join me in welcome Komla.
There you are. Good morning. Yeah. So when I look at the schedule and I saw that I would be like the fourth presenter, I was like, by the time I get here, everybody will know about how cool AI is, and I won't have any example to share. But as a practitioner of data science, I cannot do justice to my field if I don't share any cool stuff that AI can do for us in healthcare. So I set out to talk about a topic that's like very dear to me, which is like we don't have a lot of articles about it yet, is how AI can help in developing countries. Having experienced how healthcare is delivered and administered in both third world countries and also in a more advanced economy like ours, one of the things that make me dream of the future is how AI can help close the gap in some of the disparities we have in developing countries. So I wanted to start off by sharing a few cool examples of AI, and then we can also talk about how things can go wrong, showing you a few examples of AI going wrong, and also how why can things go wrong and how we can kind of try to contain the damage when it comes to how we deploy and use those AI models. So one of the examples I wanted to share is we can use AI nowadays to contain a lot of disease outbreaks, right? So as you know, like a lot of the outbreaks don't start here, but they start in those developing countries. So like assuming like if you heard about Ebola, for instance, like it started in areas that are very complex for a human to access, but like if we use sensors or like we use like even insects, right, following them with drones and all that to go out there in those complex areas and then harvest like the pathogen in the environment and all that and monitor those real time, we will be able to know, okay, well, this is about to happen, as opposed to us waiting for like a few cases to be diagnosed and then we have that reactive approach to the problem. And as you know, we have missionaries all over those developing countries. We have people in the Peace Corps. So like before we know it, those outbreaks are in our airport, in our doors. We live in a global economy. Another example that I have is that like if you look at like Nigeria, a country like Nigeria, most populous country in Africa, it has about like 0.01 doctors per thousand for population in their rural areas. So the question I always ask is that like, is the solution training more doctors, or can we have like some AI techniques that would train people on how to use to close that gap? Meaning that those people are not really doctors. So I put that image there because it's an example of a case where you have an AI trained app that can actually be used by, and not that person using it is not an ophthalmologist, but they actually can scan it, and then the app will be able to diagnose if they have glaucoma or the type of procedure that needs to be administered for that person to be healed. So we can have like a 6-month or a year training, 18-month certification for people that we train them not in medicine, but actually how to use the AI app. And also those AI app will help us gather information in those environments. And then as the information comes back to a certain center, we know exactly how many malaria drugs we need to send there, for instance, because we already know like cholera outbreak and stuff like that. As the person has those apps, communicating with a central repository in the cloud, training itself, knowing, okay, how is the disease evolving and stuff like that. So I have high hope for AI to help close the gap as far as like quickly, because we won't have, it would take 100 years to fill the gap as far as like the lack of physicians that we have in developing countries, especially with the fast growth of those populations. So having said that, I wanted I have been working in statistics and machine learning for about 16 years. So this graph is just to show you like where we are, where I think we are now. I think as far as healthcare, we're barely scratching the surface, right? So right now we have a lot of rule-based decisioning algorithms out there. From experience, people have coded some rules. If this person is a certain height, a certain weight, a certain age, lives in a certain neighborhood, or have been exposed to like street drug before and has like asthma, and maybe then they're likely to have, and they're about 40, that maybe they have a high propensity of having a cardiovascular event in the next 18 months and stuff like that, right? That's just a general rule. Simple calculator, like we understand those rules, right? Right now we understand those rules. As we're moving toward like more machine learning algorithm, we try to have AI algorithm help with diagnosis, right? So we supply a lot of input on a certain member, and then we expect the AI machine to tell us, okay, well, this person has this comorbidity index, or this person has a COPD, and they also have CAD and stuff like that. We basing those off of historical data to look at like, okay, our claims data, our pharmacy data, our provider data, to see, okay, well, if all of these lines up, then to what level of confidence the machine can tell us that this is the actual true diagnosis. So that's like the orange part there. And we want to use that information to like tailor care management, right? Like personalized care management. We want to be able to like know, okay, well, what is we can create comorbidity clusters for our member population. Like segmenting people just because like, okay, the asthma people alone will be somewhere, but somebody with asthma and COPD will be in another bucket and have a different type of procedural approach to manage their care. So with that, the way I'm looking at the future is that eventually we all have like, one of the questions that was asked, like how many people have like a smart watch or like something monitoring their, like how many steps they take and stuff like that, right? What if eventually we collect that data real time, and then as we have that information, somebody that needs to have, a diabetic, for instance, the machine can control the dose of insulin, right? Like as they're going about the business, the machine knows that, okay, well, you need your dose now, and then you carry some type of patch or something, and then it will dispense it as needed. Or like have like automated ventilators, right? Like somebody that needs oxygen, then the machine will feel like, oh, the oxygen level is low, and then like ventilate them and stuff like that. So like future state, I think it has to be like real-time driven, but like we have to have like an active learning. So basically as the person, for instance, being on insulin, the machine or like the algorithm will know, okay, well, maybe they get 3 doses in a week, but like when they're starting to get 4 or 5, there's something wrong, right? Are they getting worse? Then like, are they in need for some intervention? So those data needs to be fed back to a certain physician or a certain hospital that monitors, okay, how often this is being dispensed automatically and stuff like that, and how worse the person is getting, so we can take some action, proactive action, which leads us to the personalized medicine, monitoring every single member at real time, right? So with that being said, like let's talk about like the general, before I dive into what can go wrong, or a few examples of like AI having some undesirable consequences or outcome, right? So basically, as it has been repeated many times today, like all AI initial models are trained on historical data. So we have the historical data, and then if it becomes a model, it can be like a static model that is run in batch, that is run like once in a while. But to make it a true AI, we have to have it in such a way that it has constant feedback, right? Constant feedback so that it can retrain itself, recalibrate itself. So like in the environment, as things are happening, not only is the model predicting the possible outcome for those inputs, but also checking the accuracy of the predicted outcome at a future time to retrain itself if it gets it wrong, or to strengthen the rewarding function that it has if it gets it right, right? So if it gets it right, it will boost up a little bit of the weight for the strategy it uses. If it gets it wrong, then it will try to temper it down a little bit to adjust for the error as we go. So over time, the hope is that for those things, for the algorithm to get better over time as it's adjusting, so it will be optimizing itself as new inputs are coming in, right? So it has to have automatic learning. It needs a lot of data, a lot of fresh data, and then it has to have self-evaluation of the performance. So with that being said, the reason why I want to stop on this slide a little bit is that in healthcare it's slightly different. So like when I was in banking, for instance, I was building a fraud prevention model. So I for credit cards. So I took all the historical credit card fraud that had happened for the last 3 years. I look at the patterns, like try to network people, are they married, that is in the same household, like what kind of transaction, what was their max average ticket, and I engineered a lot of features historically, and then I built that model. And when I deploy the model, then the model will actually score every single transaction that was happening on our debit and credit card. And then if the model thinks it's fraud, we will either decline it and send you a text. If you don't respond back, then we will decline it and block your card. If you respond, it's me, then we'll just like have you retry again, right? So it was one of the cases that it was very easy to check the accuracy of the model, because you know the person. I mean, you can interact with the customer, and the customer can tell you whether or not your model was right. So you have that feedback directly, right? So coming to healthcare, so most of the risk score that we create in healthcare to predict an outcome, we try to predict like a negative outcome for a member so we can take some action to counter what we predicted. So basically, if I predict that this person is going to have a heart attack within a certain time frame, we want to take some action. We're not going to let the person have the heart attack and then see if our model works, right? We're going to take some action. So we don't have that feedback. So the very outcome that we're predicting that can help us check the accuracy of our models is what we're fighting against, right? So how do you know if I give you 100% that nothing was going to happen to, and then 6 months later nothing happened to them? Or I give you 100% that something was about to happen to, and then nothing happened to them. How did you know that you had an impact? How do you know that I didn't just give you all false positive, right? Because you don't have anything to check against. So that's one challenge in healthcare, because like measuring the performance of the model and blindly trusting the model that is doing the right thing, like is the actual outcome observed at the end of a study attributable to the model, or is it just that the model is gaming us, giving us people that are like purely not at risk, right? So a few examples of some stuff that can go wrong. So there was some article a couple weeks ago for Optum risk score, where they were showing that the risk score, they call it the impactful risk score, was biased against minorities, which means that a lot of insurance companies that are using those risk scores as part of their internal models were not prioritizing the minorities for quality care, as well as they were prioritizing the white counterpart for the same, I mean, if you take like for the same comorbidity and for the same series of chronic conditions. And how did that happen? When Optum was building their model, the target that they used the cost of care as target. as opposed to outcome. So what that means is that minorities don't spend as much on healthcare as the white counterpart. And I mean, the reason for that can be philosophical, right? Like there has been the Tuskegee experiment. People think that minorities don't trust the doctors that much. It can be language barriers. It can be a whole lot of reasons. But the fact is that if you take like the spend per member, minorities had a lower spend per member for all the insurance company compared to like the white counterpart who like see doctors more often and for a lot of preventative care. So the model was looking at spend, trying to predict who's likely going to be needing care, but they Optum used the wrong impact. So everybody, like from Cigna to Centene to Optum, and like there's already like a lawsuit in New York against United for that going on right now, and then that litigation is going to affect all the insurance company, everybody that is actually using that, right? Another example is a Google algorithm that contributed to like radicalization into white supremacy. So what Google was building a model to try to see what videos were people were more interested in. But in order to do that, what they decided to do is like to build a model that optimized the time spent on YouTube, right? So basically, people that are like more likely to be radicalized, spend more time on those type of videos. So over time, the model thought that those type of videos, those racially biased videos, were good videos for suggestions. So basically, the people's feeds started changing because the outcome that were used initially to train the model has been biased. So they were trying to, instead of predicting like profiling good content, they actually predicted time spent. So time spent on what? And then that's how it happened. And they took down the algorithm, but it's one of those things that the intended algorithm worked perfectly, but AI got it wrong, right? And last but not least, I wanted to mention like the 747 Max AI issue, right? Like it's only one single faulty AI component that make those planes crash, right? Because then it shows you an example of how we cannot like 100% be sure how an AI algorithm that is trained on historical data is going to react when it encounters something that was unseen in the training data before. So those are like a few cases of like some undesirable outcome for AI, and there are a lot of other ones that have a reference like for a few further reading at the end that you can check a few of those examples at. So then let's talk about what can go wrong, right? How can all that happen? How can Google be radicalizing people? How can a plane be crashing and killing everybody on board while like in the testing environment, everything worked fine, right? So like I said, AI models are always trained on their on the historical data and are very biased. They're very biased toward the environment that they were trained on. So we have to make sure that the context of the operation of the model is exactly the same as in the environment in which the model has been trained for us to expect the same outcome. Also, one of the things, as a head of a data science team, one of the things that I always try to point out is that as you're working in teams, right, you have to be conscientious of like, do I have a diverse team? Do I have a diversity of opinion? Do I have people that think differently, that have different background, right? Is like the group of the scientists building those models representative of the population on which the model is going to be used, right? Or do I need to consult with other people as far as how do I incorporate all the venues, all the walks of life, building this algorithm that I want to deploy globally? And you have a lot of bias. You have affinity bias. You work with somebody for 10 years. You trust their judgment. If they bring you a result, you're not going to question it, right? But it's something that may impact something, like because we have confirmation bias. I think this is going to work. I just need so and so to say, oh, it works, and then I'm going to be like, it works. So we have to be careful when building those models to make sure we're working in in an environment that's just as diverse as the whole world, or at least try to emulate and simulate that environment in order for us to create something that's deployable at scale. Because if we don't, those biases are they're gonna actually perpetuate like inequalities and inequities in society, like the IPRO risk score, for instance, not providing like the same level of care to the minorities as we would provide to the white counterpart and stuff like that, because the model is intentionally biased. So over time, those minorities are going to have necessarily continue to be having lower outcome, regardless of how hard they try to get care, because the model is not saying that they don't actually need their condition is not as acute, or those conditions are not as acute as their white counterpart. So another thing is predicting the wrong target. Going back to what I said about Google, like predicting time spent on YouTube as opposed to predicting content, or using like there was an example of an algorithm built by I think Microsoft built an algorithm called the T-box, where T-box the intention was to have T-bot do automatic tweet. So then if T-bot tweets something, the number of likes that it gets was the rewarding function, right? So they deployed it for about 24 hours, and then people figured out how to game T-bot, right? So basically, they were having T-bot say stuff like Hitler was right and stuff like that, because those were getting a lot of likes, and so they were able to change the behavior. Like the model, like somebody externally was able to game that model that somebody else built, so that the model started behaving toward like where the other group learned the model, right? So if you're predicting a metric that can be gamed, then somebody outside of your organization can actually take over your model and retrain it over time, unbeknownst to you, right? So, and then training on the wrong data. So how do we define the target? That's the key thing. How do we, the majority of medical data is available on people that have insurance or can afford copay or can pay out of pocket, right? There is a group of the population on which we're never going to collect data because they just don't use medical services because they can't afford it, especially in a country like ours, right? So if we're using claims data, provider data, hospital data, and all that, how do we account for the people that are not in the system, right? How do we know that our data is like global enough to be generalized? So training on the wrong data is one of the biggest challenges that we face, because your model can only be as good as your training environment. So that means that if somebody has never been to a hospital or somebody was never seen before, then you can't really actually use that model to score them. You shouldn't, right? So let's see. So the last one is optimizing a measure as opposed to an outcome. What do I say by that? So a lot of AI models right now try to have ROI ties to them, right? So everybody is thinking about savings, right? How do I build a model that predicts the high-risk people so I can focus on them, so I can lower their cost, I can do this, I can do that, as opposed to focusing on the outcome, the health outcome of those members. Like, regardless of how much we spend on them, like, are they going to heal? Are they going to recover? Are they going to be better, right? So if you're predicting, like, a measure is just a surrogate for, like a proxy for the target, right? So basically, if you have, for instance, if I have cost of care as my target, but I'm trying to say what's the outcome for a member, then my model is going to say that the people that cost more had a better outcome, right? Because they got more procedures, right? Unless I figure out, like, okay, do I have a survey? And then on that survey, I can say, well, I have 1,000 people, I treated them the same way I surveyed all of them, and then about 800 got better, and used that survey result as my target. So any models that is based on a matrix that predict a certain matrix can actually be gained if somebody understands how the matrix is calculated. So basically, if I'm predicting costs, once somebody is able to fit in like cohort or like synthetically engineered features that had higher costs, they can actually shift your outcome over time. And your models can still predict the people exactly the same way you expect it to be, except that the members predicted are not who you want to be treating, right? So, and then most real-time algorithms concern themselves with I'll say short-term results. So basically, it will say, I'm checking this, I'm predicting this, I want to check it 2 hours later to see if it's correct. But some of the clinical outcome takes years, right? So how do we know that the prediction today is accurate and then keep on doing the same thing over and over and over and over until we figure out that we were wrong? How far along, what type of clinical procedure should be predictable through an AI model, right? Are those that we can actually measure in the short run, or can we actually use them for studies that are like long-term studies as well? So that's one of the questions. So optimizing that. Another thing that can go wrong, right, or things that can happen is I call it prediction drift. So basically, there's a sudden shift in the data, in the operation data. So you train, for instance, and you train on a certain disease pattern. In my case, one example I can give is like flu, right? The flu virus changes over and over, right? So basically, I cannot anticipate the flu season really on past flu season, depending on, because we don't know the type of virus we're going to get this year. I mean, everything else equal. If we have the same virus like last year, I can tell you what your spend is going to be. I can get you a transmissivity level, right? So I always struggle with building flu models, looking at things like profession, right? Teachers in a household have more flu in the household than other professional. Kids in the household, school children and stuff like that. We predict that, okay, this is going to be the household that are going to be affected, that we can never tell how much we'll spend on them because of the evolution of the disease. So we can't really train a flu model and say, okay, well, if we do A, B, and C, then regardless of, we can control the outcome. So that's one of the things that, not all prior experience in healthcare are applicable to new situation. We know there are some disease, but there are always dynamic shifts in the disease evolution and population interaction that we cannot unequivocally apply history to the future. Another one that I wrestle with is that how do we know that our AI model is sensitive to operational drift? So if that changed, right, assuming that you have a change in a disease behavior, how does the model account for that? Or how does the model signal that to the end user, knowing that the operation environment is not the same as what it used to be or what it was trained on? Usually what's happening is that most machine learning algorithms will be trained to even work on insufficient data, right? Because healthcare data is sparsely populated. If we were to, there was an example earlier where we started with 61,000 people, and then we ended up with 377 that we can only work with, right? But artificial intelligence models will try to use all the data as much as possible, try to sometimes impute some of the missing data, or try to make prediction regardless of the insufficient data. So, a human doctor with not enough information is going to err on the side of caution, right? The model is still going to predict regardless. The model is not going to, so the model doesn't have that sensitivity to the cost of getting a wrong prediction. So basically, the way I think about it is that if you have somebody that's about to have a certain procedure, and that procedure is a life or death, and you have a human doctor, the decision made there is not clear-cut, right? You have to talk to the family, you have to do some stuff. But if you base it off of the model, the model, if the model gets it wrong, it gets it wrong. The model is going to say, okay, don't give him the procedure, and that's it because of some historical, and it could be wrong because the model is not 100% accurate. But what's the financial impact? What's the psychological impact of basing that decision off of like a machine learning algorithm that doesn't have the empathy or that doesn't know the patient as well as that human interaction that they'll have with the care provider, right? So the risk is there's like not all scores will be equal. So the question is like how do we know how confident the model is in its prediction? Most of the current AI algorithms that we have don't have that, right? Like if the model spits out a score, how confident is the model about that score? How sure is the model? We don't have that because most of them are just black box algorithms that we can hardly interpret, right? So basically, if you look at a person, we need to get to a point where when you take like a person, this person scores 80% for a high-risk cardiovascular event, for instance, we need to be able to take all of the parameters and make a rational interpretation as to how the score came about, right? If we cannot do that, then why would we trust a black box algorithm that is giving us something that we can use, but we don't know how it got there, right? One example that I try to use all the time with my peers is that AI is a fast-moving engine. So from the time the automobile was invented, it took like nearly 50 years before we got to the seatbelt, right? But has somebody thought about those accidents that would happen for 50 years from the get-go? Maybe we would have built in the seatbelt in the automobile before we start using them, right? So like, do we learn from history and try to put like boundaries around AI first before we go global with it? Or do we try to fine-tune AI at our own risk as we're making progress, right? Like what would be the cost of any possible thing that can go wrong? We need to know that, right? So if you think about also human interaction, we have automation complacency, right? It's like when one example that my mom gave me was like after my dad passing, she now needs to remember everybody's birthday because he was there to remember, so she didn't care, right? So that type of thing. So if you have an AI doing some stuff for you, over time, you're gonna lose the ability to cross-check those things. So like our nurses, our clinicians are gonna trust the AI algorithm and not cross-validate the output, right? Because over time, if nothing is going wrong, we have that complacency. Though the machine is telling me to give you this drug, I'm going to give you this drug. Or the machine is saying this procedure is appropriate for you, I'm going to do it without knowing if the machine has decayed over time or if the model is actually working as appropriately, right? So also, one big thing is like what happened to an AI model if we have a change in the data, right? Like a drug safety alert, for instance. A model is built and it's prescribing a certain drug and the drug gets a recall. Automatically, all of a sudden, the model has no more history to train itself on, right? Because that data is just bad data. So then if we deploy the model, like we deploy the model globally, how do we pull that back, right? How, do we get to a point where every single hospital, every single entity has to have their own model so they can have total control? Or like, how do we get that? If somebody is using that model in China, for instance, how do we get all those models off the shelf? How do you turn them off? Or with lack of data, then do we let the model reinforce the wrong algorithm that it's been using because it was trained on the wrong data or data that's not really that is not really up to the standards of the public health and safety, right? And one of the things is like also models can actually like hack the reward function. So one of the example that I have is like, so there was some algorithm for like image recognition. And in that algorithm, what was happening is that they're trying to say, okay, if you have, like in nature, like in a forest environment, if you have like some trees, then, okay, recognize the trees. If you have like some kangaroos, recognize the kangaroos and all that. So they spent the whole day taking pictures of kangaroos in forests all over. But except that, like, while they're taking pictures, half the day it was sunny and the other half it was rainy, right? So it was cloudy. So they brought the whole thing back. They created the model, built the model. The model performed very fine, except that, unbeknownst to anybody, the model was trying to distinguish between a sunny day and a cloudy day, as opposed to. So the model was very accurate because there was a lot of kangaroos when it was cloudy, and they deployed the model, and then when they deployed, the model wasn't recognizing any kangaroos because they deployed in broad daylight. So,
Komla.
Yeah. Okay. Yeah. So, 2 minutes. Okay. Yeah. The one other thing that this was talked about a lot, but I think I have this, and I have this in my office too. Like, we should make sure that ethically, we shouldn't create any AI models that does any harm, right? There should be a do no harm. There should be compliance. We should have laws and guardrail around any AI models. It should be fair. It should not discriminate against any type of group of people. It should not, and it should be open for contestability. We should be able to criticize the output. Like if I go and then you tell me, if I come to a doctor and the doctor tells me, oh, you can use this model on me, I need to question how my result came about, right? What do you know about me? And that type of thing. It has to have accountability. Like people should be going to jail if they build a model that's impacting people, having negative outcome. Like who do we hold accountable? The person that built the model, or do we have to have new laws for the AI bots and stuff like that, right? Transparency is another thing. Privacy of our data, and also like any single model that we use in healthcare, we should ensure that the benefit outweigh the cost for us. And then I have those 10 questions that I always ask about every single algorithm that we have. Like, is the model accounting for diversity? How was the training data labeled, right? What target did you choose? And was the data imbalanced? How did you handle the imbalances? Is your operational data context the same as your training data? Is your system capable of noticing and adjusting for operational drift? Is your prediction, can you interpret your prediction, and how trustable can I be? How confident is the actual model in its own prediction? Yeah, and then the last one is that, is the model prediction and interpretability available to the clinicians that are going to use it? So more to read on, like I have a few things here, but in general, I think I'm out of time. So, thank you, and then I'm open for your questions.
Oh, questions over here. Thank you, Komla.
Sorry.
I was interested in your idea of using surveys to back up, because especially someone like Centene, when you're dealing with Medicaid and Medicare policies, you've got very distinct subsets of population. But historically, the minority community has not trusted the medical research community because of things like the Tuskegee syphilis experiment. How do you deal with the non-responsive level you get to inquiry?
Yeah, so it's not an exact science, so it makes the work a little difficult. So you have some complete information on a small proportion of our minority, but given that we have a very homogeneous population on Medicaid, so underinsured and uninsured members, you can actually use that small population to extrapolate a lot of inputs on the missing data. Meaning that, for instance, if they're part of the same household, or if you know that they're related, you can actually say, okay, well, if the parent has asthma, this is the likelihood of having asthma and stuff like that. So we try to do a lot of extrapolation. It's not exact, but sparsity of our data is a big challenge because our members, they don't fill the form and they don't see it. They don't go to the hospital unless we have good data on ER. But that's about it. They'll go to the ER and go home, but they won't even know who the PCP is. So that type of thing.
Well,
yes.
I was moving this so I could actually see your face and
Okay.
talk at the same time. So thank you so much for addressing bias and really calling attention to that issue. And to your just most recent conversation, we do have local qualitative research focus group key informant data that says that many people within our African American community believe strongly in the power of research for improving care. And so I think to be mindful of being inclusive and using folks as we develop algorithms to do reality checks can be important in actually building the data capacity. But my original thought was I was reflecting on the St. Jude's talk and then your opening about West Africa. And I wondered what we are learning from those contexts about use of technology, even just cell phone and texting. I had spent some time in Tanzania about 10 years ago and was really struck by the power of social networking. So not just what do we bring to those contexts, but what might we learn from?
Yeah. So I think like back to the third world countries, a lot of things that are happening there, like, are unbeknownst to like the developed world. Like, we have cell phones and social networking that's very developed there. And whenever I'm traveling the African continent, I see that, like, how they use their mobile phone to do a lot of their activities. They were far, far ahead of us. Like, people pay bills with their phone minute. People send money to each other with their phone minute and stuff like that. And if you really want to get any campaign, you can use the social networking. If you want to curb Ebola, if you want to curb Zika, dengue, or the Nile virus, you can actually use the phone network to communicate with them. They don't have TVs, they don't have radios, but everybody has a smartphone. So I think if we can develop app for them to check like their blood sugar level, for them to check like, okay, well, how's my heart rate and stuff like that. Give it to them for free, and then have those apps send us those data back here. We will know exactly the change in dynamic in the population all across the globe, so we can anticipate if something is going to happen, which lead us to lead to a better healthcare here at home. Yeah.
Yeah. Thank you so much for talking about race and bringing that into it. That is so important for bioethics and for the Banner Center for AI, for everything. My question is, you showed the picture of the phone, and it's taking a picture of that woman's eye.
Yeah.
That's an example of an app that you can extend the doctor to a place where there aren't any. How do you keep that kind of technology from being colonizing? Like, we're trying to get away from colonialism in the 21st century, right? But that data is streaming back to the West, right?
Yes.
It's coming to St. Louis, you know what I mean? And it seems to me like it's remarkably colonizing. How do you get away from that?
Yeah, so thank you for the question, Jason. Like, I beg to disagree with the colonialism part because, like, I think healthcare should be a global issue. Like, and I strongly believe that, I mean, the healthier they are, the more likely they're going to be able to take care of themselves and to develop their own countries. And the saying that, okay, well, we're not going to use this technology or we're not going to stream the data to people that are ahead of our technologies, right, to help us lead a healthy life, is saying that we're going to, in year 2100, we're going to have 1 doctor per 1,000 in Africa. And I don't see that as a fair thing to happen in this global world. It leads to like data protection, right? We have to have ways to tell them that data privacy. We're not going to use the data to say, okay, well, we're going to isolate you guys or exterminate you guys because you have this type of disease or you have this type of outcome. So how the data is going to be used is going to lead to colonialism. But if the data is well intended, just for healthcare purposes, I don't think the Africans should be worried about it. Yeah. Thank you.
Okay. I was thinking that it sounds like from your presentation you're advocating that before we actually implement artificial intelligence, we need to develop artificial wisdom. So what are some concrete steps, and from a data scientist point of view, we should be taking to integrate the concept of artificial wisdom? How can we build that in a model when it is such a nebulous concept?
Yes, I think one of the first things that, especially in healthcare, one of the things that needs to happen in healthcare AI is that the physician and the health practitioners should help define what the target or what is it that we're trying to achieve. Instead of having like data scientists and computer scientists try to figure out, like in the case of the Optum risk score, for instance, try to figure out how they can model something, the physicians should determine like the scope of work and what the outcome needs to be, so that the target variable or what we're trying to get to is clinically sound, coming directly from the medical field. If that happens, we will know that like the outcome that we design it are targeting something that's like medically accepted, right? And if that means that if we have those models in place, that means it will be okay. The wisdom part is coming from somebody that actually knows health. That's a provider. It's not somebody that can just build a machine learning algorithm, throw a random forest or a nearest neighbor algorithm to some data and spit something out. So I think for healthcare, it has to be like a balance in physicians and clinician needs to be involved as much as like the computer scientists. The programming part should be left to like the data scientists, but actually the hospital, the doctors, and the healthcare community should be determining what type of algorithm needs to be put out there, or what type of algorithm should be researched on in AI, as opposed to just data scientists coming up with stuff to like just sell to the community. Yes.
To make a bit of a plug for the Veterans Administration and a couple of the topics we have already brought up, issues of race, that people who are interested in collaborating with VA data, we have a larger, a more complete medical records for individuals that are minorities, and we also have a lot of veteran input, or actually patient input, in terms of the wisdom. What outcomes may they be looking for? Our whole health program particularly looks at not just what is the blood sugar readout, but how is the person enjoying their life now that they've reached a particular clinical readout. So that's one thing that, as you were saying, I was thinking, you know what, we actually might be a little bit on to that. So. Yeah,
and that leads to like how different the models and the algorithms should be depending on your population, right? You have to build different models for Medicaid. You have to build Medicare different models and AI algorithms for like the VA population, for your Medicare population, and even for your marketplace or commercial. You cannot, like, there's no one size fits all, right? One example of for the VAs, for instance, right? Like, you will notice that like for the behavioral health, they tend to use applications as opposed to going to see a therapist, right? And one example of that, like, those people have been to places that none of us have ever been, and those are tough guys, and if you're going to break down and cry and roll on the floor, you don't want anybody seeing you. I mean, you want to do it in front of your phone, right? Like, you don't want to talk to a therapist. So if you build the model should account for the fact that those people are like tough-minded. Like, they try to swallow their pride, they try to hide their PTSD and all that. You have to account for that, and you cannot generalize that model to somebody that has not had the military experience, for instance. So everybody, like, we have to get to like personalized healthcare, but we have to be conscientious that like every single algorithm, like just because it's out there, it should not be applicable to all healthcare. That's what I'm saying. We need to get to a point where it could be like every single hospital have their own AI structure, or every single provider has their own AI structure just to be safe. There's no one size fits all. We cannot generalize.
Last question.
Hi, you talked about the concern that we forget how to do those things that we don't practice, forgetting the phone number because you've never had to remember it because it's in your phone or your husband remembered it. Have you seen in other industries or with other kind of applications of AI the mitigation of that concern and people kind of addressing and making sure that people don't forget how to do what the AI is doing for them?
Not really. Like, I think what we've done to try to circumvent that is try to build algorithms that are interpretable. So, because people are going to do that, as like they're going to start trusting the machine over time, but you have to have some way of auditing the output of the machine. So if we can, like, it's like doing a quality control. We should be able to pull some randomly every now and again, pull some score out and try to reconstruct that to see if it makes sense, right? And if it makes sense, then they can keep trusting the machine because it's just human behavior. Like unless you tell them to not use the machine, there's no way around it, right? Over time, that's going to happen. But having those quality control, and the one thing with most of the AI algorithms at this stand right now is that there's so much black box that you don't have a way to audit the output, which means that like, either you trust it all over until it breaks or until something is happening for you to be reactive to it. But like, we need to have more interpretability in AI, understanding like having quality control, like using like, okay, well, let's every now and again randomly check a set of members to make sure the model is still doing what it's doing. I think that's the only way we can circumvent that and keep the AI safe in the hands of the clinicians.
Komla, we'd like to thank you and
Thank you.
for your presentation.
Thank